That was a fitting introduction for our next speaker, and Dr. Norman Bine is going to talk about the treatment of hand veins. And Dr. Bine practices in St. Louis with his lovely wife, and he's been a friend of mine for years, and he has invaluable knowledge, not only in veins, but everything else in the world. So I'm going to turn it over to Norm.
Thank you. I have nothing to declare but my genius. That was Oscar Wilde, I believe. We do a fair amount of cosmetic work as the insurance reimbursement goes down. And we all know the insurers are in purgatory and they are on their way to hell. There are reasons for people coming to us. Self-esteem, their hands look older, the hands look more masculine, and as ladies say, they look just plain ugly. A lot of this in the older women is due to the fact that you lose a fair degree of subcutaneous fat. That's another perfect example. And this is what you see in your office. These are younger folks who have that same similar problem, but they have the sub-Q fat. Fragile aging skin do not do these old folks. The skin tears easily, we use no stitches, and they heal poorly. We stay away from people on Coumadin because of the hemosiderin deposition. There is a euphemism for insane called body dysmorphic disorder. People will never be happy with what you do, and we avoid those folks. I think the secret is talk to the folks beforehand. What we do preoperatively is we give prophylactic antibiotic, usually Keflex, 2 days. We take photographs, we get the informed consent. Very importantly, the first patient that I did was my wife, and correspondence from her was, do not do the entire hand at one setting. You get a fair degree of swelling. We do half a hand at a time. So it's a half, it's a half, it's a half, it's a half. And we do them 2 weeks apart, so the collateral flow will come in. We use tumescent, same as for EVLA. We use the 18-gauge needle for punctures. We use, can you hear me okay? Oh, I'm sorry. We use an 18-gauge needle for punctures. We use Susan Bates number 10. Instead of spending $150 for hooks, I think the number 10, as Ron taught me, is the best hook for removing veins. I use a pinch tease, which we'll show you in the movie. We use an 18-gauge needle to separate. We don't make cuts. We have an assistant. She applies light pressure, and it takes me approximately 20 minutes to do this. As I say, the remuneration is well worth the time. I do the procedure, my associate just does all the wrapping, so on and so forth. This is a classic example of what a hand works. We will show you the movie at this point. And what we're doing is marking just that half of the hand. That's important. Do not take out all of the veins. Use half a hand at a time. This is tumescent, which everybody knows. And the great thing about the Midwest is when you stick a needle in someone and you hurt them, they apologize to you. I'm sorry, doctor. So this is the local anesthetic. Once I've marked it, I can put as much of this in as I want to. It decreases the bleeding, and it makes everybody that much more happy through the procedure. This is here we're using a 18 gauge. Now, here's your number 10 Susan Bates hook, which is going in, and we'll get a hold of a vein. There's a vein. Grab it. Bloodless. If the patient complains, we give a little extra anesthesia. And it's quite comfortable for the patient. This shows you the vein sub-Q. What I aim for, what I'm doing now, I'm giving a little local distally. The vein that is very prominent will not snap back. If you go far away from the vein, that vein will snap back and will not bleed. Stay close to the vein on the surface, and that's going to bleed for you, and you don't want that. So here's the vein coming out. I'll show you the length of it. It goes all the way down there. This is bloodless. Again, I go high above, and here's again the needle, which will, with this edge, cut it out. Here's another example, and once again, let's see what I get here. So here's another vein coming out. We do much larger than these, but this is a good example of the type of procedure. It's easy, it's painless, the results are spectacular. I'm not exaggerating here. And you have a happy patient. And once again, I'm cutting the vein with a 16 gauge, proximal and distal. It helps if you're good with your hands. And here again, here I'm using 11 because I know just how much I pulled up already. And again, we just cut under the skin so we don't have to stitch anything. And that's a pinch technique. That's a nerve. That's how you differentiate a nerve from a vein. You want to leave that alone, just drop it right back in. And this is the one that was right at the base of her thumb. Always watch out for the nerves because they'll, although it's not much of a problem, they'll complain otherwise. Now, all of you're looking at now is less than 20 minutes. And once again, I'm cutting. Great. That'll give you the length right there. This is the dressing. Very little dressing. Wrap it once. Put one of your blue scrubs on. Always leave the middle finger free because in St. Louis you can't drive unless you got a middle finger. Wrap it up. Make a little cut. It's a hand dressing, minimal hand dressing. Full range of activity. People do what they want to do. This is following the procedure, usually 2 to 4 weeks afterwards. We go after the tiny veins. These are the veins we do not do phlebectomies on, but this is all part of the same cost of doing the procedure. So we go in for the smaller veins and we finish up the job. And essentially the patient tells us what she doesn't like and we finish it up with the injections. And again, cotton ball and patient full range of activity.
Are you using foam or liquid?
I'm using foam.
What percentage?
The least percent I possibly can use, 0.1, 0.13. The least, the better.
What do you use for closure?
We don't close. We just, at the very most, we use a steri-strip. We use no closures because everything is done through needle sticks. So there's no stitches to remove. People pretty much take the dressings off in a day, shower, do what they want to do, full range of activity. I have no complaints with how well the procedure goes. Is that the end of the movie?
Correct.
There we go. So light pressure, 24 hours. Small ice bag, if you wish, elevate above the heart. We like arnica. If the patient's a bruiser, we start the arnica montanum pills beforehand, and we use arnica lotion afterwards. The very most we use is Tylenol, especially if we've been using if we've been using sclerotherapy. But Tylenol is all these folks need, and as I say, back to work in 24 hours. Again, the smaller diameter veins can be injected. These are the percents that we use with the Tessari method, which everybody I think here knows. At 27 gauge butterfly. We do this for residual veins after the phlebectomies. We usually wait several weeks before we think about doing any injections. Now, the larger veins we do not inject because of clot or trapped blood. We don't want the people coming back to the office and draining these areas. We want them happy from day one. They'll tell their friends, and that increases our business. Alternatives. These are pictures. On the left is before. That's 5 days post-op in the middle, and over there on the right is 1 month. There's no scar, no stitches have been used, and this patient was especially pleased. She was a physician in town who had a Fitzpatrick type 1 skin. If you don't know, Fitzpatrick 1 is like an Irish girl with freckles and translucent skin. A 6 is an African American. She was a 1, and she was so pleased with what we had done with her hands. We ended up doing her feet also, both feet. Before, 3 weeks post-operatively. Before, 1 week. I think that looks damn good. Other areas to consider: large facial veins, as Peggy talked about, abdominal veins we've injected or ligated, depending upon what the ultrasound shows, the foot veins we talked about. Chest veins, almost always we're injecting, however. This is another example of, I just threw this in because this was so much fun, an old woman who said people didn't like people staring at her, so we went ahead and did a phlebectomy on her here, and I said to her, "Would you like me to touch it up with some sclero?" And she said, "No, thank you, doctor." She was more than pleased. That's the great thing about what we do. People love what we do. For years as a chest, vascular, and abdominal surgeon, I can tell you, hardly anybody knew what I did. All they saw was a very large incision and had a lot of pain. But these people, this is the happiest practice you can imagine. Now, that's interesting. St. Louis is the only town that built a monument to everybody who left the town. Incredible. And we came up here the same day the Cardinals did. The Cardinals were 2 for 4 against the Cubs. And you know, I'll tell you, I think this conference is 4 for 4, so I'm ahead. And I thank you very much for your time.
May I ask Dr. Bain a question, please?
Yeah.
The abdominal veins, if they're collaterals that indicate IVC obstruction, I'm concerned that people are going in and ablating those or sclerosing those without investigating why they have them.
Well, I think that's foolish. There's an awful lot of people who are foolish. I think you have to evaluate the entire patient. We had a very nice couple of slides of people that we have investigated the iliacs bilaterally and the IVC, and both were the epigastrics or hypogastric, whatever you want to call them. I ligated both, and everything disappeared in like 2 weeks. But she wouldn't let us take another picture, because after I had done all this work, she got her entire body tattooed. But you have to investigate. If you see anything abdominal, you're absolutely right. If you see abdominal varicosities, there's no question you need to look deeper. You know, the trick is there's an old law in surgery that says good surgical judgment comes from experience, and experience comes from bad surgical judgment. Mm-hmm. So always best to investigate deeply, I think. Thank you very much.
Another question.
Oh, I'm sorry. I'm sorry. Oh, well, we have a laser for brown spots. We use a 694, which is almost an Alexandrite. And what we do for our patients is we see a fair number of people with we used to call them liver spots, so you see I'm older than you. The brown spots, we take the laser and we hit 5 or 6 different areas on the hand veins and so on and so forth. If it works, because you don't know beforehand if it's going to work or not, but if it works, they'll sign up, and it's incredible. They do not come back with a 694. So that's all laser work.
I do something to add for that, because I work with laser a lot. So for that brown spots, we can use the 694, but we're not only talking about wavelength. We have to see also the pulse duration. So for that, we can even use the IPL if correctly used. It goes very well. And another kind of laser is called Q-switch, also very good for that.
Sorry, what is that?
Q-switch.
Q-switch.
Q-switch. Yeah.
He uses the Q-switch. We use the Q-switch because we also do a fair amount of tattoo removal. Yeah. And the Q-switch 694 is spectacular for the brown spots. Right. And we use the other 1064, 532 for other problems. So there's another cash payment business. Thank you.
Thank you. If you can afford a laser, that's the problem. Our next speaker is from Brazil, and has wide depth of knowledge and experience in venous disease, and runs a lot of courses in Brazil, well known throughout the world. But Dr. Cucci is going to come up and talk about optimizing sclerotherapy.
Thank you very much. So here are my disclosures. Before talking about how to optimize the spider veins, I want to give you some information. Everybody knows that if you consider some type of telangiectasias, up to 75% of women has some concerns in the leg in Brazil. That gives me something around 109 million legs to treat. The aesthetic marketing in Brazil is growing, reach almost $45 billion US. And Brazilians are willing to spend their money in the abdomen, hair, buttocks, and of course legs. So a quick math, for a $45 billion US market, where 65% are spent on treatments, that give me $25 billion if 29% of women are willing to invest in their legs. That give me something around $7.2 billion US to go for. In US, vein treatment and sclerotherapy are between the top 10 dermatologic procedures, and also under the top 10 expenditure on major non-surgical cosmetic procedures. In 2004, that was more than $100 million US. So if anyone still are thinking that is important to optimize your cosmetic outcome, I think we're going in different directions. The problem is that we have in literature very few randomized trials. So we do something like this, my sclerotherapy technique. So each physician has its medical formula. So let's talk about how to improve your cosmetic outcome, how I do it. First, we have to prove that we're doing a good job. Why is that? Because both patients and physicians do not remember the before treatment aspect. This patient came in to my office complaining of the result after 2 sessions, but what she didn't remember how it was before the 2 sessions. It's called subject similarity. To avoid that, we must have object documentation, so standardized photos, that's mandatory. Of course, we can do it through a lot of photograph devices or even your iPhones or smartphones. We have a lot of device apps and softwares to help us doing that. So the first tip is prove that we are doing a good job. Second one, make a good diagnosis. Why is that? If you're going to Edinburgh vein study, considering class 2 and class 3 telangiectasias, we have almost 50% of GSV or SSV insufficient associated to that. If we consider CPC2, almost 80% of the limbs show some kind of reflux, even on GSV or SSV or both of them. Also, if we take the lateral of the thigh, this study was putting on a Doppler in the reticular veins in the lateral of the thigh, and we heard sound after leg compression and after liquid injection in the telangiectasia. So this proved that our communications between telangiectasias and reticular veins and between reticular veins and deep venous system. Also, more than 50% of the Brazilian telangiectasias are associated to perforator veins, and we have almost 12% connect to a feeding subcutaneous vein, and another part connect to a saphenous vein. So here's a quick video showing the relevance to make a diagnosis on feeder veins when necessary. We can see right there, right here, a telangiectasias, and then we can see that subcutaneous reticular vein feeding that telangiectasias. Another thing is the relevance of ultrasound when telangiectasias are resistant. This patient had 4 previous attempts to treat, but when we see the ultrasound, we see right there the reticular vein and then the connect to a perforator. So I use this kind of algorithm to approach the leg vein treatment. When we have symptoms or when we have reticular veins, ultrasound is performed always. I always do my own ultrasound, as other colleagues said before. And always go for the feeder vein when necessary. So that's a good approach to improve your cosmetic outcome. So we have already proved that we're doing a good job. We did make a good diagnosis. So next step is know as many techniques as possible. Because a good approach is when you talk to your patient, you see how motivated your patient is to cosmetic or symptoms. You also see your clinical examination, and then you make your treatment go. With correct anatomy and hemodynamic analysis, you see the technical possibility and the treatment strategy. Then you reach your possible options to treat. You see the advantages and disadvantages of each technique, the patient preference, and if it's available for you. In the 90s, we used to use the evidence-based medicine a lot. The problem is the EBM, it depreciates intuition. Nowadays, we do the shared decision-making medicine. It considers the individuality of the patient and also shared responsibility. So to do that, you must know a lot of techniques. This is a list of techniques that you should know. You can be amazed what kind of, a lot of more that we have. Of course, this is my facility in Brazil. I do have a lot of techniques available, but not only you have to have this available, but you should know how to use it. So I'm gonna give you quick tips on transcutaneous laser and liquid sclero. Doing transcutaneous laser is very challenging because we must know physics to do that. So the parameters and settings depends on wavelength, pulse duration, the spot size, and also the radiation exposure. But to know that, should know the vein characteristics and also physics. Just to demonstrate that, we have a 1064 6mm spot size. You see nothing happens in that telangiectasia. Why is that? Because it's being doing with the wrong parameter. If I do with the correct one, we just see the telangiectasia vanishing. So the important thing when using transcutaneous laser is no physics, even for reticular veins. You can see that reticular vein with the correct parameter is going to vanish right after the treatment. So to treat spider veins with transcutaneous laser, know the correct parameters, know what parameters your device provides, because not all devices provide the same parameters. And then you can see if that particular telangiectasia is treatable with laser. With liquid sclero, one should know that one of the complications of liquid sclero is the ulceration, and there are some colleagues that think that this ulceration is caused by a reflux from a little vein to a little artery. So the suggestion is to make a small volume in each puncture. Also, what we do want is a lot of zone 1. So if we do want a lot of zone 1, we should make a lot of punctures. Also, as said before, with correct sclerosant and sclerosant concentration. If we use a higher concentration than necessary, hyperpigmentation is a fact. So what I do is the progressive management. I started with dextrose, and then, if necessary, polydocanol plus dextrose, or increase polydocanol concentration. I don't have Sotradeco available in Brazil. This is a little performance on sclerotherapy. You see, I'm using a air cooling device. So to treat spider vein with liquid sclero, know the correct pressure, know the correct sclerosant and concentration, treat better with less complication risks. And last thing is eccentrical compression. When you put elastic stocking, you think that you are doing a good compression, but it's not totally right. If you see here, the part of the body that is going with less compression is the lateral of the thigh. So I ask you, is this a rare clinical presentation for you in cosmetic? Of course not. So if pressure is force divided by area, let's push a small area. That means eccentrical compression. So this is what I do with these cotton balls. This is an example how it is effective as a compression with no ecchymosis or whatever after puncture. So this is how you can start improving your cosmetic outcomes on spider vein treatment. Just a quick before and afters. This is only with laser. Also reticular vein, only with laser. This one was tried with dextrose, no succeed, but after one session of increasing the power of the sclerosant, we gave a good result. This is one sclero liquid only. This is dextrose polydocanol foam, polydocanol liquid. Also, facial veins, we can do with laser. This is an example. This one too, one session, single session. This one, single session also. So there is no magical formula, and unfortunately, I have to say you that when treating spider vein, you have to deal with the unpredictable. Thank you very much. This is my contact if anyone wants. Thank you.
Before I start, I never had that good a success with reticulars in a 1064. I did a lot of reticular treatments and then did a phlebectomy and still had endothelial cells, so I stopped doing 1064, except in the posterior aspect of the leg. The popliteal faucets seem to do better in any place. So, but I just can't afford to have all the toys. So we're going to talk about combining microsurgical techniques, sclerotherapy, and heat modalities. And a lot of this stuff that we're going over is stuff that I've actually developed by spending a lot of time in the dermal path lab. And I've done a lot of biopsies and all kinds of treatments of veins, reticular veins. And I developed a concept that spider varicosities are related to cutaneous venous hypertension. It can be the symptoms may be a few scattered spider veins, a reticular spider vein complex, or a venous ulcer. And so if you know the pathway and interrupt the pathway, you're halfway there. So this talk is more about what you do after you interrupt the pathway to go all the way to get results. So I don't have any disclosures. I'm still waiting to be courted for something. So cutaneous venous hypertension is the etiology of spider telangiectasia, okay? Sclerotherapy is the only modality in most cases will not alleviate cutaneous venous hypertension or will take multiple treatments. So your patients want to see results and want to see them fast. Failure to relieve the elevated cutaneous venous pressure will lead to one of the following conditions: slow resolution, no resolution, TM matting, which is really a troublesome thing to occur after you've done a treatment, or recurrent pathology. So most spider veins are secondary to reticular vein pathology. Okay, most reticular pathology is secondary to volume overload. So there may or may not be a connection deeper. It may be only when you're treating this patient that the only pathology is the reticular pathway. If you imagine yourself going down an interstate and coming to an exit, that's exactly what a spider vein is. The reticular vein is a throwaway, a branch of the reticular vein coming off, the exit, that's where the pathology is. It's not the reticular vein. It took me a few, when I was doing, how I learned that, when I was doing punch biopsies for different strengths of sclerosis in solution, I would see this vein coming right up into the punch biopsy. And then also another important thing happened, that when these patients came back, there were no more spider veins. One treatment, they were gone. So what I was doing was not only taking out the exit point, but I was also taking out an eclipse of skin, which disconnected the spider veins even further. And the reason you have spider veins to a certain level is that venous hypertension, pressure, can only go so high. That's why you don't see veins going up into the abdomen from the thigh. So there comes a point when the pressure no longer is able to dilate those small veins. However, those veins are still connected to areolar spider vein and arterial in the skin, and veno in the skin. And the other reason you don't get in trouble is that venous hypertension doesn't dilate arteries, okay? It just dilates the veins, so it makes it very easy to treat without much chance of arterial injury, except if you get one of these little fistulas. Another point that to prove that, when we were doing punch biopsies, for our different procedures where we were doing phlebectomies through the punch, we would actually inject sotradecal, different concentration, into the skin, where we're going to do the punch, and then look at the biopsy after we did the phlebectomy. Absolutely no effect at all on the papillary or reticular dermis. Doesn't do anything, okay? Well, of course, we stopped at 0.3. So we're just trying to do normal clinical situations. All lateral reticular veins are secondary to a perforator. The paper that I think was referenced that Bob Weiss put out in late 90s localized the perforator to the knee level, but what he was listening to was a reentry point. The perforator is high in the thigh. That's where it comes off from the femoral vein. So you must, as Dr. Kucinich said, you have to localize this with an ultrasound. Put your ultrasound depth at 2 centimeters and scan that reticular. It'll show you if there's a perforator. Now, this is another lateral reticular perforator right here. I'll show you the clinical, but you can see there's a lot of flow in and out. This is where most of these are superiorly. And so the blue is blood going out and the red's a return. And it connects to a fairly good size reticular vein right there. A lot of flow in that, a lot of reflux. So the valve's not working right. You'll see in a minute the dilatation of the lateral reticular system from this perforator. Okay. No. If I see a lateral reticular system complex in a man, I wonder what's going on, because that's usually a phenomenon only with women. Once in a while you'll see one not associated with pregnancy, but the women are usually athletic. But most of the time this is secondary to pregnancy, and it comes after usually the second pregnancy. The vein dilates up so much because of volume overload, it never goes back to normal. They may or may not have deeper pathology. This just shows you where the lateral reticular perforator was. This is a lateral view. The one we looked at was right here, and that's where most of them are. They're high up in the thigh. And they also dilate the reticular vein. You may have varices down here, spider varices, you may have them here. But the avenue is a perforator, and you have to get rid of the perforator. So identify it, and we inject foam. You can use 0.1% foam, inject it close to the perforator, and it's gone. This reticular pathology may also be from the GSV, SSV, or AAGSV. And this lady has a AAGSV branch with a lot of reticular spider varicosities in this area right here. So of course, you have to treat this, or that won't go away, or you'll make it worse. An ultrasound is imperative. You have to do an ultrasound if you're going to treat these patients and get really quick results. I can't stress how important it is. You scan the reticular vein to the origin, because when this reticular vein, you'll see the spider veins coming out. Scan that reticular vein back all the way and see if it goes into a perforator or the AAGSV or the GSV, okay? Or it may just be isolated reticular pathology if you find no communication. But branches off the reticular vein cause the pathology, not the reticular vein is the pathway. The branch is the actual final pathway to the reticulars. So in this case, this is one of the studies that we were doing to try to determine what was the ideal concentration of sclerosant solution, which I'll tell you now is 0.1% sotradecyl, period. Across the board, polydocanol is not as effective. Endothelial cells are still present. 0.2 sotradecyl and above will give you staining. 0.1, we didn't have any staining in the patients that we did the clinical trial on. So this is what this shows, is this is the spider vein right here. This is about 400, 500 microns below the skin surface, even though it looks very superficial. They have a lot of papillary dermis and reticular dermis around them. This is the reticular vein branch coming right up. It's very rarely seen. A lot of times you don't get that good a picture, but here's the reticular branch coming out subcutaneously up into dermis, then it comes into the spider vein complex. Excellent demonstration of what really causes this pathology in most patients. Get this right here. Now you can see here the blushing. This is almost angiogenesis after previous injection because she still has some flow. So angiogenesis is either new vessels occurring around a blockage or there's flow around a previous area of inflammatory changes here after sclero. So what we're going to do, now unload this, I'm going to inject here into a little vessel I see that's patent. You can see it flushing out nice. So when I unload this circulation by doing this punch, that'll make most of this go away. And I'll show you that in a minute. Now this is the area where we saw the little angiogenesis. We've injected it. This is tumescent that we put right here. So we're just going to do a little punch, this 1.5 millimeter punch, right like this. After we do the punch, we just take this thing out. And you can see right here is a reticular vein coming out. You can see it right there. So what we've done is we've taken out the reticular vein, and we've also disrupted the cutaneous spider varicosities as the reticular comes right up to it. So this is a really nice, useful technique to getting rid of this, and we'll show you how we close this in just a second. Okay? Yeah, I don't show the closure, but actually the way you close it is you just take a 5-dexon suture, you put it through, pull the ends tight, little glue, wait 30 seconds, pull the suture out. Beautiful cosmetic result. They can't tell anything's been done. And all those vessels are gone in one treatment. That's it, when they have that pattern. I tell you, use the laser work real well up in this area. But here we can't get the laser because there's not enough blood volume, so we're going to do a little bit of the Van Gogh. We put a little bit of Dermica on. See, it's working very nice. And we've used Van Gogh on her before, and she does very well with it. Now I'm using a ballet at this time because they're so superficial, they're not very deep. I'm just going to put a little bit more Dermica on. This prevents a lot of the skin sequelae. Do a little bit right here. These are much too small to inject and don't have enough blood volume for a laser, so this is a great option in these patients is to use ionic thermolysis or Van Gogh. We're using it 20% power. So she's going to have a really nice response with this. So what we do with that is that just anything that's small that you can't inject, you know, I don't like IPL. I mean, in good hands, it's probably okay. I used IPL from the beginning. I hated it. It's much easier to use this little needle and just use pinpoint applications and it goes away. And the good thing about that, there is absolutely no permanent damage with this, none at all. I have seen none. So, I mean, it takes a little experience, but it's a good one. You can also do lasers. A 1064 in my hands doesn't do very well, but if you have a smaller spot size, increase the joules, you got to use cooling. I use a 940, which does very well, gets rid of the veins, the spider veins. But if you're going to do one thing, you know, learn how to do relieving the cutaneous venous hypertension. So one thing you got to learn, and there's different situations which you have to do a little bit different in all of them. We can't go through everything, but if you do that and sclero, that's all you need, really, except for the little small red ones. If you have, you know, we use the Omic for that, so and it's a lot cheaper than a lot of these lasers. So the optimal wavelength for a laser is 532. Skin penetration is limited. That's the problem. 940 works well, as long as the diode is powerful enough. You got to make sure it's double powered. We use it in conjunction with sclerotherapy, but I don't like that. I don't like to use, I mean, there's reports out there about, yes, it does make it go away quicker, but if you're using chemical and you're using heat, you may get some staining. So I prefer either just use the laser, do the punch or the phlebectomy, come back and finish up if they have anything. But most of the time, I don't even use the laser unless they have a lot of spider veins. I just don't need to. I can just do sclero and that's it. So the conclusion, surgical approach in sclerotherapy, in my hands, gives the optimal result. For veins under 3 millimeters, I use Omic. They're too small for adequate sclerotherapy. And so that's it. I have a couple of clamps, a little hook, some tumescent, Omic, and I can treat most people who come to the office. Thank you. Now I'm going to have my very lovely wife come up, and for all of you that don't know, Peggy and I met in Haiti working. I was working in the mountains, and she was working by the ocean in different clinics. I'd run out of supplies and food, and I heard about this clinic down there, so I went there to see what I could pilfer and stay around for a week, and I met Peggy, and we've been together ever since. So she works with me hand in hand in the office. She does these procedures as well as I do. She does sclerotherapy better than I do. And she's going to talk about billing for the cosmetic and also for the other types of procedures. Peggy?
My topic is billing, and as you know, you can't possibly cover billing in 10 minutes. So I'm just going to go over a few of the nuances. No disclosures. Documentation is the key to reimbursement, period. You must know the correct codes, and you must bill for all procedures. You must have a good and easy EMR with coding and automatic billing. The consultation note and the ultrasound note are separate. It's possible to bill for an extended visit and bilateral ultrasound, even if you do offer free consults. We offer free consults in our clinic, but if the patient has venous insufficiency and will need procedures, we will tell the patient we're going to bill your insurance. And at that time, we just do our ultrasound, H&P, and we just do it all at that visit. It takes Dr. Bush about 5 minutes. And this is just a copy from our EMR. You can bill for extended, you can bill for intermediate, depending on how long it takes. And I was told by a nursing friend that's here, Maria, thank you, Maria, that there is a consultation code I didn't know about that's for referred patients. And I'm gonna have to check this out, but it's 99243, and apparently you get a higher reimbursement. So I'll look that up and make sure we get that on in our system. And here's just a copy of the billing for the ultrasound, 93970. Documentation. When you're documenting, you must document how the symptoms affect the ADLs, and all of this should be put in your EMR. If you have a good EMR system, they'll already have it done for you. You need to document analgesics. You must understand pre-authorization, pre-certification, and predetermination. You can predetermine all your planned procedures at the same time. Otherwise, you'll risk denials. Just because you get a pre-authorization does not mean it's a guarantee. I'm starting to get emails from doctors where this one particular case is Blue Cross Blue Shield asked a doctor to pay back $100,000. He was doing ultrasound-guided sclerotherapy procedures, which should be covered, but they're refusing to pay. And then I heard of another one here in Illinois where they're starting to do audits. So more than ever, make sure you're documenting. The predetermination and pre-authorization do establish medical necessity and determines the benefits if they're available. You must document a trial of conservative therapy. Your patient will come in and you'll ask them questions. Sometimes they say, I don't have any symptoms, and they have all these varicosities, they have stasis changes. But if you start asking appropriate questions, do you have to elevate your legs? Do you ever take pain medicine? All of a sudden, they're saying yes to everything. People get so used to their disease process that they don't even know that they have these. But they have to wear stockings, and if they don't, you need to fit them for stockings. And I'd even carry the stockings in your office. You can make some extra money. Include the SEEP. You don't have to include the venous severity score yet, but I think that's coming down the pipeline. Always take photos, just like he said. They never remember what they look like. They get used to their new look, their new legs, and they're like, I don't see any difference. And you pull out that before picture, and they're like, I did look pretty bad. On the ultrasound report, because you'll submit this separately, note the size of the vein, the size of the varicosities, seconds of reflux. Not all insurance companies want all this, but you're going to get that one that denies it and says, why didn't you have that? So you might as well just do it. Many insurance companies require measurements at the SFJ and reflux at the SFJ. Just go ahead and document it right at that time. Insurance may request presence or absence of aneurysmal dilatation below the SFJ or tortuosity of the vein. Sorry about that. You should know your medical insurance criteria and make sure the staff checks on policies. Things change daily, it seems, and they don't even notify you sometimes. Carefully review your insurance contracts if you decide to participate in those. Consult with your top payers and review all the policies. Insurance plans are always raising the bar for coverage, always excluding things, and there are many exclusions now for venous treatment, so pay attention to those. And after listening to the talks yesterday, it sounds like our reimbursements are much slower now, and you might want to start looking at these cash procedures. As far as managing your money, make sure you have a good staff that follows up on collections, collect the co-payments, and be on top of your own finances. Sometimes patients have high deductibles. Now you're hearing people say, I have $5,000, $10,000. They might want to pay cash. They pay cash in our clinic all the time. They don't want to pay those deductibles. Try to become proficient in doing the cosmetic procedures, as everyone's been saying. Leg veins, facial veins, hand veins. They can really add up. Consider aesthetics if it interests you. There's a lot of things you can do for aesthetics. The tattoo removal, you can do, our whole practice, 80% is cosmetic. So you can do all kinds of stuff. Sell the compression stocking, you'll make thousands of dollars. Sell skincare products. Make sure you lock up your skincare products, though. You can delegate more to your nurses, your PAs, nurse practitioners. This is just a sample of vein codes. And by the way, I have my email address on here. I'd be happy to email you anything you want. We do have a website called veinexperts.org. This is all on there. You can just go on there and get it, too. This is a sample of my template. If you want a sample of my template, I share everything. I share all my forms, pre and post. I share what we charge. Just email me and I'll send it to you. And once again, it's on our website. Know the new Medicare guidelines coming out. They're starting to deny and refuse. I see here they're not going to pay for the Clarivain. There's different things coming down the pipeline, ultrasound-guided sclerotherapy. They're getting tougher. So you just have to be familiar with all this. This is Obamacare and insurance companies. And this is Shark Week, so this is my contribution, and that is us right there. So we need to unite and work together against the insurance companies. There's my email address. Thank you.
Is there any quick questions before we, yes?
I have one question, Dr. Bush. If I get rid of the perforator, then that should take care of the reticular veins and the spider veins.
If you get what? I'm sorry.
The perforator.
Oh, the perforator.
Yeah.
No, because reticulars communicate. And if the valve's bad in the reticular, it's going to refill from someplace.
Oh, I see.
Yep. That's the good thing about veins. You do veins, you'll never go out of business because they always keep coming back someplace.
You still have to treat the reticulars.
Yeah.
The reticulars are usually the problem, along with perforators. If you don't treat the reticulars and you just treat the spider veins, you're just going to have more of a mess, more spider veins, and an unhappy patient.
Yeah, he was talking about doing the perforator. So we meet back here, I think,
she's got a question.
Oh, I'm sorry. There's a question? Come up to the microphone, please, because.
She can't.
Oh, I'm sorry. Could you just? Take the microphone over to her. That's fine. Thank you very much for that. Thank you, sir.
I don't know what she said.
Hello? Okay. I've seen a lot of alcoholics as the etiology of telangiectasia of the bulbous area of the nose. Have you seen those? The alcoholics?
Yeah, the red veins?
Right, the red veins, right.
Well, actually, the main cause of red veins on the nose is sun.
But
it
these
can
are
cause alcohol,
alcoholics,
too.
though.
Yeah, you can get that. The bulbous type, yeah, you can use this device on that. They go away.
Ron, stand.
Oh, but most of the cause of red veins that we see are from the sun exposure. These red veins here. I
Right.
think what you're seeing is a more bulbous type.
Right.
You can use a laser on that, or I'll make anything you want. Right. Laser would probably be better on those because they have such blood volume.
Okay.
Yep.
Thank you.
It's all right. Okay, so we'll be back here in about, I think, 15 minutes. Get everything set up. Thank you.